Thank you everyone again for having me. So after watching some of these talks, I'm realizing that I do not have the tricks of the trade down, but hopefully, even for people that are considering pivoting in their job, I think that this would be relevant to you. There's a lot of stuff in there for the residents, a lot of stuff in there for other people, so we'll see how it goes. So I have no disclosure except I've been out of fellowship and in practice for 3 months, so I think that's important to say. So I do not have it figured out. However, I've worked at the following: 4 major academic university hospitals, 8 community hospitals, and 2 VA hospitals. And I did a lot of locums in my fellowship, so I feel like I've had a good flavor of different areas of the country, different hospitals. I've worked in the South, I've worked in Tennessee, North Carolina, Missouri, Illinois, Connecticut. So full spectrum. And I also want to say there are no perfect jobs. This is any profession in life. I think that you can even listen to celebrities on their podcasts and they're always complaining about something. But the goal is to place yourself into a situation for success. If you're looking for that perfect pot of gold at the end of the rainbow, it's not always going to happen that just as easily as you think it is, even though you finish your training. So for the residents, while in your chief year, learn how to be fast and efficient. You can learn how to operate. You might have done 100 circumcisions, but can you do 8 circumcisions in a day? I think that's very important. I think admin days are very good. The culture is shifting from where you're just at the hospital for 100 hours a week to now you actually get time to go to the doctor, go to the dentist, get your car emissions report checked, study, work on presentations, work on your M&Ms. I think that's awesome. But take admin days for when you really need them. Otherwise, you need to go to the operating room, you need to go to clinic. I promise you're never gonna regret the days. If you have an attending that, hey, let's say that, this is someone that, there's a PGY2 assigned him for the day, and he's doing 5 circumcisions. Well, if you're able to go in there and just bang out their circumcisions with the PGY2 and the attending sits on the computer, that's a really good day for you. That's a really good, valuable skill set no matter what practice you're going into. Steal from your attendings and your co-residents. You should have 100 copies of the testicular pain printout that Dr. Terlecki showed on Friday. That is so important. He's putting it out for the world. Do you have any idea how much you're going to not look forward to those visits, and now you have a standardized way to do it? That is important. Steal Epic templates. Steal the handouts. Steal the QR codes. Whatever it is. This is all very important stuff that's going to help you maximize your efficiency. Last minute checklist, go to the doctor, go to the dentist. A lot of times you forget about it. You guys have more time to do it now, make sure you're doing it. Get 90-day prescriptions. When you leave one part of training and then you transition to another place, it takes a while to get a primary care doctor. So if you have prescriptions, make sure you ask for 90 days ahead of time. It'll take a lot of stress out of you. Set yourself up for success to minimize stress. Save more money than you may need. You get a moving bonus, you're probably going to need more. Begin packing early and buy your boxes and packing supplies from other places besides U-Haul. It's very expensive. They have these giant warehouses where you can get boxes and packing peanuts for literally half the price. Figure out what you need to do if you're moving to another state. Your car registration, how many days do you need to do that? They told me in North Carolina I had 30 days to show documentation that my wife and I lived in the state of North Carolina. That was very stressful when I first moved here. Figure out your doctor's visits. You can even email them ahead of time if they're booked out for months and say, hey, listen, I'm one of the new faculty, I'm new to the area. These are all things that will help minimize your stress. And then save all your documentation. You're gonna need these for every hospital system that you go for. If you ever change jobs, you're gonna love it that you have a big folder that has everything. Take pictures of your diplomas, that's a big one. And save your Epic templates like we talked about. To fellow or not to fellow, a lot of people say, why did you do a fellowship? Do I need to do a fellowship? I basically say, if you're looking for, is there a skill set that you're currently lacking, or do you just need more reps, right? If you want to go out and do robotic prostatectomies, everyone can do robotic prostatectomies, but you're probably going to need a mentor in the beginning if you're not going to do a fellowship. If you want to go out and do IVC thrombectomies, you probably need to do a fellowship. But I think the most important part is, do you want to understand a disease process more thoroughly? That's not to say that you're never going to understand that disease process more thoroughly with time, but if you want that disease process really mapped out in your head when you're starting your practice, I think that's one of the best ways, one of the best reasons to do a fellowship. Research year versus no research year. I think one of the main benefits of research year for me was it was just a really nice break. You're an adult by the time you get to your research year. You're treated more as a colleague, as a junior attending. No one's really breathing down your back. It's a really good year to really reset, to really study, to spend time with your family, and just to have a more regular job. And also you can do some locums and make some money. So it's not as much of a year of lost revenue as you may think. And I also want to say your mentors kind of care about you. Yes, we care about you, but everyone is very busy. So you really need to look inside of yourself I care just as much about the chief resident who's doing a 2-year SUO fellow as I do about the chief resident who found a private practice job that's good for his family. Everyone just wants you guys to commit to something and be happy about it. And then we become excited for you, and we want to help you as much as we can to get to that goal. This is the trifecta, and the unicorn's in the middle. I don't know if that unicorn ever exists. Hopefully someone has found that. And we've all seen the data, high rates of burnout. I think that a lot of aspects that come into urology burnout is the fact that there really aren't that many people that do what we do. People see blood in the urine and they freak out. People see a tube coming out of the genitourinary tract and they freak out. No one can really manage it as well as we do. That's why we're getting all these epic inbox messages. We get the ER calls in the middle of the night. I assure you that general surgery does not get half the epic inboxes as we do. Everyone works very hard. So the way that I kind of looked at my career is, am I okay with being surrounded by fires and having to put out fires, or getting a lot of mosquito bites during the day? I don't like getting a lot of mosquito bites during the day. I really enjoy it to where I just can concentrate on my practice, and I'm not getting phone calls all day from the ER. I'm having to field and triage a lot of these calls throughout the day. So that was one of my big reasons for going into academic medicine too. I really, love working in a team setting, and that's what I got. So specific questions I had: work-life balance. I think that these were the 4 things that I really looked into. The things that I want to emphasize with this is I do a lot of intravesical chemotherapy for non-muscle invasive bladder cancer. I needed to make sure that we had a good program in place. I think that that's very important for people that have specific interests and pathways, because that can be very stressful if you're not able to offer patients the resources that you need to set your patients up for success too. For the OR availability is a nationwide problem right now. I have friends that are 2 years into practice and they still don't have dedicated block time. They're literally doing their cases on Friday nights. So everyone's only going to highlight the good when it comes to jobs, but you really need to dig into, do I have block time? How much OR time is actually available? How much robot time is available? How many endo cases can I perform in a day? How many endo cases are my partners performing in a day? What is the turnover time? That's a big one. What is the turnover time in your hospital? These are all things that will drive you crazy if you enter into a situation where you weren't expecting it. I find that when it comes to call contracts, in some contracts, it actually says you are doing 7 nights of call per month. Any other call that you do, you get compensated this much. If that's important to you, I think that that's something to really keep in mind. In my former institution, they did not have it in there, and then next thing you know, there was a bunch of hospitals that were bought up, and a lot of people got delegated out to do call. That's something to keep in mind moving forward when it comes to how much is call important to your work-life balance. Other economic considerations: mailbox money. I don't have it. You guys can teach me how to do it. Investing in surgery centers, ESVALD machines, sounds awesome. Someone tell me how to do that. Keep this in mind when you're in practice. The physician is judged by the 3 A's: ability, availability, and affability. I think everyone's going to hear that at their chief resident graduation. So when you're starting out, enjoy the lag time. It ends quickly. You're going to be slow at first. You're going to feel like people are judging you. I guarantee you that's going to be over very quickly, and everyone's just happy that you're there. So don't worry about it. Accept that you're going to be slower. Figure out the equipment you need, and if it's negotiable. When I first got here, I did my cystectomies a certain way. There was a certain type of retractor I used. We didn't have that at the hospital. I now use a Bookwalter. Not a big deal to me. But there are some equipments that I said, well, I really need this, and they were actually able to get them. So that's all things that you can kind of meet with your clinical nurses. Align yourself with your allies. I have a text chain with radiation oncology, medical oncology, where we're always discussing patients. I feel that improves efficiency. You can do it through Epic, but a lot of times it's easier if you just do a quick phone call. And a lot of times it's easy. I'll say, hey, I got this patient here. Do you mind just seeing, do you have availability today? And they'll see them on that same day in the cancer center. It's awesome. Advocate for yourself and your patients, but be nice. Everything is not going to be perfectly set up for you when you get there. Make sure that you're very nice. Okay, that's all I'm going to say. And don't make every patient a project. Delegate when appropriate. One thing that I found myself doing in the beginning is I'll see a patient and I'll need them to see radiation oncology, medical oncology, maybe interventional radiology, and I'll say, I'll follow your chart and I'll call you and then we'll come up with a final decision. That was crushing me. What I've been doing is I say, I'm going to book you a return appointment in 6 weeks. In the meantime, I put in all these referrals. By the time the 6 weeks ends, if you've met with all these people and you want to send me a message and say, hey, I just decided on surgery, then just send me that message. Otherwise, in 6 weeks, they show up in my clinic and we can just have that conversation again. I don't have to worry about it. It's all kind of out there, and I let them know, but you have to advocate for yourself and your own care. Introduce yourself to the community. I thought that I was gonna need to do this, but at the same time, I've been so busy that it's kind of worked out. People have been reaching out to me. It's been awesome. But there's been some situations where you can get the billboards. I think those people are doing great. I want to have a vasectomy practice. Sounds awesome. Give out your cell phone, give out your email, say yes, but not to everything. Don't set yourself up for disaster early. If you're coming and you're saying that you want to do all the tough cases, I assure you everyone's going to send you the tough cases. Make sure that you're not taking on the cases that are out of your spectrum in the beginning, because that is something people are going to be paying attention to your outcomes, I assure you. Learn how to be efficient. This is something that is not sustainable for me long term, but every Sunday I'm in the clinic for at least 4 hours. I'm pre-charting, I'm looking at my patients. A lot of it is because I get a lot of referrals from the VA, and I have 100 pages of notes that I need to look through. And at the same time, I'm reaching out to my mentors. All my former fellowship people, they all pick up my phone call because they know that it's, especially on Sundays, they know it's going to be straight to the point. Pick up like, hey, how are you? Good, how are you? Good. All right, I have this guy, and we just boom, boom, boom. I have 5 patients ready for them. We come up with a game plan. That way I'm not having anxiety about seeing the patients that week. When I see the patients in the clinic, I already have a plan for them, and I offer them everything. These are very complex patients. I found that pre-charting helps me in the future. I need to work on some Dr. Terlecki skills and become more efficient, but for now, it's helping me early in my career. Alrighty, communicate with your clinical and OR team. I don't need a UA before every cysto. I felt like that was something I just said, I don't need anything. Literally just put them in and ask them if they're symptomatic, and then just go for it. Do you want patients to have questionnaires? Do you need a flow PVR before every BPH patient? Don't drown in your inbox. Set yourself up for success when it comes to telling them that just because they get a result in their inbox, that it doesn't mean that something bad happened. So a lot of times I say, I'm doing a lot of cystos. No news is good news for me. If you see something that says atypia or inflammation, I don't care about it. The only thing I care about is if it says high-grade urothelial carcinoma, that's when you're going to get a phone call from me. And I do call those patients and say, hey, listen, here's our options moving forward. I'll tell them the same thing about their CT scans. I'll say, you're going to get a CT urogram in a week. If you don't hear from me, that's good news. There you go. Utilize your nursing pool in the same way. Set boundaries regarding test results. I tell my patients that I've gotten my prostate biopsies, no matter what this shows, you're gonna have a post-op in 2 to 3 weeks. I can't spend an hour on the phone talking to you, but I'm happy to spend as much time as you need in your post-op visit. Tackle your downtime, call your patients in between, and don't put off the dreaded phone calls. Everyone knows what the dreaded phone calls are. You're really not looking forward to having this conversation. I would say make it a priority to get those out of the way. That way you're not dreading it. There's lots of resources within the AUA. There's lots of podcasts, which we've gone over. Reach out to your colleagues, too, to learn how to document and bill. Ask a lot of questions. If you're going into academics, I very much believe this. Residents need to operate, residents need to operate, residents need to operate. There's give and take. You also need to identify your learning curve. You need to become efficient, because until you're comfortable with the procedures, then you can't just give up that portion of the procedure because you're scared of it. So there's a balance, but in the same time, residents need to operate. Pick your battles. I tell my patients there are 100 people involved in your care by the time you see me to when you're leaving the hospital. It's a whole team. Mistakes are going to happen. The other day I had a patient that right before he was about to go to sleep for a cystectomy, we realized he hadn't seen a stoma nurse. I'm not going to jump on anyone's throat about that. Mistakes are going to happen, but at the same time, you just kind of got to let that stuff go. Everything was fine. Be confident but transparent. When you're starting out, everyone's going to want to know that, your experience and blah, blah, blah. So I always tell people, listen, here's my training record. I certainly haven't done as many as so-and-so. I'm happy to have you see my partner who's done 10 times more of these. If you want to go to another institution, I'm specific in who they should see. That way it becomes that I'm advocating for their care too. I'll say, go see Dr. So-and-so at Duke. He's done 10 times more of these than I have. I think I can do a good surgery for you. But if people are asking about a second opinion, encourage it. I promise it'll help you out. And it's okay to say no. There's always going to be opportunities to serve on unpaid hospital committees. I assure you, there's a reason why people offer those positions to everyone. There's a good book I read. It's called Essentialism. It basically talks about how you maximize the things that you're doing well while minimizing all the extra parts of your life. I think it's a good read for anyone who's really looking how to say no to more things to free up better productivity for the main concerns in your life. Complications are going to happen. There's been books written about it. You just have to accept that. And don't forget about your vacation time. I recently was reminded by my wife, like, hey, are we ever going to take a vacation? How many days of those you get? I'm like, oh, yeah, we guess we should. Take care of yourself. If you can get on a routine where you work out before work, I promise you, you will never regret that. It becomes a lot easier once you get out of residency because we're not rounding at 6 a.m. And don't suffer in silence. Lots of people around you have gone through this. There's lots of resources out there. And everyone's replaceable, even you. And even though you start to start having more financial freedom, there are some other bills that pile up. Spa days at the Grove Park Inn, for one. You can love your job, but your job will not love you back. In conclusion, I know very little. And that's all I got.
Your biggest hurdle in starting a new practice, coming right out of fellowship. What do you think that's been?
I would say that that you really can't overstate how the operating becomes the easy part. The hard part is the clinic management and getting them properly worked up to the operating room. That's something that you really don't get that flavor in residency because you kind of show up to clinic, but you don't understand all the steps that go into it.
That's a great answer.